appreciate the opportunity, and I apologize that I'm not able to get there in person, hopefully in the future. But I congratulate you and your center for taking up this mission of heart failure and cardiogenic shock really as a key component of mortality that we are tackling. I'm going to talk today about strategies for weaning mechanical support system. There's a lot of discussions on, of course, when to put the MCS, which in itself it has a little bit of nebulousness to it, but it's very important. Whatever we put in, we got to know what to do with them. And to really set the stage, it's key to understand the journey of the patient who's going through shock. And this is the flow diagram that was put forth in 2017. I believe this is the first scientific statement addressing cardiogenic shock. And when you go through the journey, there's various destinations you reach. And today, really, our focus is going to be on complete explant of MCS at the time that you recover, because when you're palliation and end of life, you take it out too. That's not what we need to talk about. Also, the discussions about transitioning from BIV support to univentricular support so you can facilitate the next steps, especially for LVADs, is what we'll discuss briefly. And it's very important to kind of keep in mind that on a daily basis, we have to ask ourselves this question: is there a probability of weaning or not? Because if you decide up front that you cannot wean, then you know which path of journey you're taking in the context of mechanical circulatory support. So the first question that comes up is, are we ready to even think about weaning? And I want to embark on the concept that you have to not just think about the body, because the treatment of shock has a big focus on improving the body, which is LFTs, the creatinine, the rest of the organs. But if you're taking out a mechanical support, you can't forget the fact that the machine was not just supporting the body because the heart's not able to, but you were providing unloading and resting for the heart, and also you were increasing coronary perfusion. So you have to think about this, whether by taking out the mechanical support, are my parameters of the heart favorable to the point that I can sustain the heart? So a checklist of questions that I go through, not being validated in any studies, are, the first question I ask is, how severe was the context of mechanical support initiation? Was I coding somebody when I put in this machine in versus saying, well, the index was low, I put it in, will make you think about the risk you're embarking on. And what is the extent of MCS support? Is it a balloon pump? Is it a BIVAD support? Is it a ECMO? That grade of support also defines the sickness and the risk you're taking. Very important is this concept of, what did I do to improve my chances of the heart doing fine by itself? And things like PCI to revascularize someone coming in MI shock, BIV in certain individuals, even though it's out of the indication to do BIV in someone with a mechanical support. And sometimes it's the opportunity of medical management where someone is naive to it, and you've noticed an opportunity that they can handle medicines. And of course, reversible causes like myocarditis treatment. And the probability of success in weaning is an area which is struggled with clear evidence, but right now there needs to be investment in this evidence in this particular area for science to give us some predictors. And importantly, lastly, the bailout strategy if the explant fails. And if you answer these questions, in my mind, you're on the right direction in making some decisions. A recent publication, which is the second scientific statement that I've seen from AHA, is about escalating and de-escalating. So if you focus on de-escalation in individuals, of course, there's a plethora of things we have to monitor, because it is almost that you have done something to save somebody's life, and now you have decided that we are okay to take it out. So you have to be careful in monitoring all aspects. I want to point your attention to the fact that I personally think a combination of imaging along with invasive cardiac monitoring is necessary for us. And of course, the rest of the body, the lab markers, and renal output and other things are extremely important. So in the context of hemodynamics and imaging, and the way I look at it is, if you just rely on one parameter, especially because things like mechanical supports like Impella skews your normal understanding of an EF and skews your assessment of an MR. So that's why I personally recommend a combination of both these aspects of assessment of the heart. And I kind of say that AI is artificial intelligence, but NI is natural intelligence. And for your natural intelligence, you need multiple variables, just like you compute in your head. And for a complex systems like cardiogenic shock, the more variables you have, the better it is. And it's also important to remember that the post MCS removal and explant needs high vigilance and follow-up of hemodynamics. So I say, don't be a SWAN hater. And I know this is a whole area of discussion on utilization of SWAN, but when you're explanting an MCS, it's very important to monitor this. Moving on to Impella weaning, depending on which Impella, the concepts are the same, but 5.5 stakes are a little higher because you're providing higher support. And say a similar concept of stable hemodynamics, and people have described using imaging criteria, which is the TVI and mitral annular velocity. It's a little bit of a struggle for me in my mind because ability to get a good amount of information with an Impella and the aortic valve is a little tough. But if you look at a survey that was done by Randava et al., 50% of the centers just dropped it down from P9 to P2 and saw how people did. And then the other centers, you drop it down 1 to 2 levels every 4 hours to reach a P2. And that's kind of what we do, and I would recommend. Between P2 and below P4, I would have a word of caution on anticoagulation so that you're not taking a risk of thrombosis. And we have the picture up here reflecting this wean, and I want to point your attention towards this cardiac power output listed in the current Smart Assist platform. And this becomes a very useful tool while you're cutting down the flow in this representation that you see. And the concept is in an Impella, when you have cardiac power output, which is calculated by this formula I have here, it is a combined cardiac power output of the heart and the pump. So if you're cutting down the pump contribution to it and the power output remains the same, you're essentially validating to yourself that the heart's able to compensate for the lesser flow. This has not been validated, but that's the concept to use to make yourself believe that actually the heart might do okay without it. If the power output drops as you cut down the P level, then you know that the heart's not compensating to maintain the power output. These are a few examples that you see where in this, the Impella P6, it is a patient in the cath lab who ended up having a PCI and had a cardiac arrest. And if you notice, as we cut down in P4, the EF looks a little better, and at P2, it still looks about the same. And then potentially, you know, you could say you could explant this. Of course, you need the other parameters we talked about. This is somebody who arrested in the cath lab with non-ischemic cardiomyopathy. Interestingly, it was a shorter, so in 3 days, it looked like the EF improved. And this was not a true end-stage non-ischemic cardiomyopathy patient that recovered and was explanted. In this condition, in this particular figure, you see that this is an example of Impella 5.5. When you go from P8 to P2, notice that your flow, this is an older device, so they don't have the Smart Assist up here for me to show, but notice the hemodynamics on what happened in this individual, especially you don't see pulsatility at all as you drop it. These blips mean that the heart's not really pulsatile. And then your wedge at P8, the wedge was about 15, but over here the wedge went up to almost 30 that you notice. So, and then the bottom line fact is even at baseline, this individual was tachycardic at 128. So really not a possibility of explant in this individual and probably dependent on MCS. The other pump that's not that prevalently used is a tandem pump. The concepts are the same of hemodynamic assessment in this pump, but the way you wean it down, again, you could cut down 0.5 liters per minute every 4 to 8 hours. And in some situations, you could drop it down. I would, again, use both imaging. It's a transseptal pump that essentially unloads the left atrium. So if you're cutting it down and your wedge is going up, you know that you're not ready for it. And in all these pumps that support the left side, I want to remind that RV failure, a lot of these cases when you have LV support system, RV failure actually portends bad prognosis. So as you're weaning down the left system, you always want to be mindful if the right is getting worse or not. ECMO weaning has been extensively studied, and I have this right-sided pressure volume loop such showing a concept which I think would be stressed in other talks, where by putting in an ECMO, the afterload of the heart goes up so much that the work on the heart goes high. So in general, if you do an ECMO alone and don't unload, you're not resting the heart, you probably won't have a good ability to recover the heart. So understanding this concept of arresting the heart in an ECMO patient probably is the most important concept. So in an ECMO patient, you want to maintain stable cardiac hemodynamics at a lower speed. And then there's been some imaging guidance that's been validated as you cut down the flow with an LVOT VTI and then the systolic velocity of the mitral annulus. And typically what we do is kind of wean down up to 2 to 1.5 liters as long as they're anticoagulated. And then, we do a ramp study with echo and hemodynamics to assess some of these parameters so we can have an objective assessment of it. And then in some individuals, you can slowly wean, but you can't go too low and leave them long, especially for ECMO for clotting issues that you might run into. And this is an example of a patient who had graft failure because of rejection. And then you notice that this is ECMO along with an impella in their unloaded LV that you notice here, and give Thymo, and you're slowly seeing improvement of the heart, and finally leading to turn down of the flows at 2 liters. You see that the heart has recovered here because of the rejection treatment, which is reversible. And then finally, we were able to take the ECMO out and then leave the impella in this particular images that you notice. And then you see here that the EF has improved remarkably, that the impella is almost getting squished. And I think in this individual, we were able to take the impella out soon. RV support system weaning is probably a tougher cohort, especially I didn't talk about specifics on weaning of the ECMO for RV support, but similar concept of decreasing the support with a CVP goal of 10 to 12 and MVO2 saturation greater than 55% is what's recommended. And quickly, the concept of using the same principles, the concept of going from these BIV support systems to a 5-5 axillary system if somebody is not weanable to discharge, so that they can then be supported to recovery and LVAD, is something as a strategy the machine transitions can be used. If somebody needs a BIV support system, then you'll have to use a 5-5 and a Protect Duo and then bridge them to the next level. So in summary, essentially you go through this algorithm to see whether end organ has improved, and then are they stable on just low-dose inotropes, go through your checklist of hemodynamics, labs, echocardiography, and if they all meet that criteria, you use the device-specific increments that we talked about, repeat this comprehensive assessment at every stage, and if you don't meet this criteria, then you failed wean attempts. You move on to discussions for bridging to transplants or durable VAD. If not, you're able to decannulate. It's important that if you decannulate, think about the bailout or quit plan and have that in place with the multidisciplinary team, so that you don't pull out the MCS and you're debating whether you need to put it back or not. But with that, I will end my talk, and this is my email. If you have any questions, I'll be very happy to answer.